Good evening. Good evening, ma'am.
We are live now. I open the room and open the lodge as well as for open the room for attendees also.
Good evening, everyone. Good evening, Thomas. Good evening, Deepak.
Good evening.
Good evening.
Harita
Good
ma'am.
evening.
Hi, Om. Good evening.
Hi, sir. Good evening.
Good evening.
Welcome home. Good evening.
Ma'am. Thank you.
I'm hoping that your quiz will be so tough that you won't be able to answer anything.
Well, I hope so. We get more answers. That's
But the good news is that we did not participate.
No, I tried my luck last time. Didn't work out very well.
15 seconds is enough for an answer.
Yes, ma'am.
Asmita,
Yes, ma'am.
15 seconds for the answer. Okay.
Okay, for each question.
Yes, for each question. Not
Okay.
more than that.
Oh,
Good evening, Appinder, sir. Good evening.
Hi, good evening.
Good evening, Dr. Jaykumar.
Good
Hi,
evening.
sir. Good evening, sir.
Good evening, sir. Dr.
Good
evening. Sirji, RG, what happened to your beard here?
Yes, Swami Sharanam.
Very
Planning to go
nice.
next week. Next week to Sabarimala. Next week after
Good.
COVID. I know.
Good luck. Good luck. Very nice.
Thank you.
It's looking more like that of the Kochukulai, sir.
Maybe from the same
Yes.
state. So how are you, Prakash?
I am
How is
quite well,
Aparna?
sir.
Okay,
well.
Appandev.
How are you every time? Yeah, fine, sir. Very nice.
Are keeping your thyroid, Indian Thyroid Society is keeping on your toes.
Yes, it is.
Sarida.
These clinics have assembled all together. So I think these are the good clinics. At least for a couple of weeks, we can meet every week.
Hey. If anybody of you is interested in writing some chapter in textbook of endocrinology by in the Endocrine Society's new edition, if somebody is interested in writing a chapter, you can contact me. I happen to be the section editor for thyroid. So,
Sure, sir, we will.
anybody is really interested in writing, you know that our textbook, Sarida Bajaj first and second edition, now it is going to be brought out, third edition is going to be brought out.
Sure, sir. I'll write to you, sir. Yes.
Namaskar. The
Good evening.
Indian Thyroid Society is a vibrant and inclusive platform for healthcare professionals who are passionate about the thyroid. We invite you to join us and make a difference in the science, research, knowledge, care, and advocacy in all things thyroid. We have context-sensitive continuing learning programs that address the needs of clinicians, trainees, and experts alike, on-site and online. Our flagship journal, Thyroid Research and Practice, with its short turnaround and all articles ahead of print format, is an ideal vehicle for your research publications. We invite you to join, participate, network, and grow with us. To know more about Indian Thyroid Society, visit the website www.indianthyroidsociety.in.
Arun?
A very good evening to everyone. This is the session 6 of our ITS thyroid clinics. And we have this evening the dialogue, quiz, and monologue, what promises to be a very exciting session. To conduct this session this evening, I request Dr. Prakash Keswani, who is a senior professor in medicine and endocrinology in SMS Medical College, Jaipur. He will introduce the moderator and the speakers and run the session from now on. Thank you, Dr. Keswani, for taking over from now.
Thank you, Dr. Arun, for introducing me. At the outset, I shall like to congratulate ITS, particularly Madam Bajaj, for initiating these good clinics, which I am able to see for last few weeks. I also congratulate Dr. R.V. Jayakumar and thank Madam for giving me this opportunity to be with you all in this evening. Today, we have a very interesting topic, medullary thyroid carcinoma. Unlike other carcinomas of the thyroid, it is slightly more malignant. And the difference is whenever we diagnose patient, then we always look for some other tumor like FEO. If it is present, we have to deal with it. And then we go for the cytogenetics, and then we also screen siblings. So we treat not only that particular malignancy, but other malignancies, and also help the siblings. This fascinating topic will be dealt today with the very brilliant speakers. And today we have very brilliant endocrinologist with us, Dr. Arpandev Bhattacharya. He is the professor and head of the endocrinology, JJM Medical College, Bengaluru. I request Dr. Arpandev Bhattacharya to start this session.
Thank you very much. Thanks, Dr. Prakash. Good evening, everybody. Thanks, Indian Thyroid Society, headed by Madam Professor Sharita Bajaj, Pramila Pillai, Dr. Odun. Thanks very much, putting me in the right place where I belong, and that is in the steep learning curve. So I am probably will benefit maximum from today's thyroid clinic. And we have 3 sessions today. One is duologue, then we'll have a quiz, and then we'll have a thyroid ultrasound, thyroid nodule. First, we'll start with the duologue. Now, I was just searching the meaning. It's actually very interesting to see that first time the word duologue is used in 1864. And it reads that a play or a part of play with speaking roles for only 2 actors. And I'm sure we'll make it as a multi-log because we'll all be interested in learning. For the audience, please put your question, comment in the chat box so that we can pick up. So today our dialogue will be with extended endocrine department of CMC Vellore, our very own Thomas Paul, professor and head of the department of endocrinology, and Dr. Deepak Abraham, professor of endocrine surgery. I think we will start it, Thomas, the way you want to go on. I have another rule of timekeeping. So before 8:40, we'll finish this session. Then we'll hand over for the quiz. Over to you, Thomas.
Yeah. Thank you so much. Thank you, madam. Thank you for all the introduction and opportunity. Of course, Dr. Deepak is doctorate in Sydney University is from medullary thyroid cancer. So he's a good resource person. So he's going to moderate the session. We will start the dialogue. I will start sharing the screen.
Could you allow us to share screen, please? Yeah. Could you see our screen?
Yes, sir, it's visible.
Yes,
Thank
yes.
you.
Yes, we can.
Thank you once again to the organizers for this invitation. It's a pleasure to be back to the Indian Thyroid Society platform. I was there a couple of weeks ago on a thyroid nodule assessment, which Arun had invited me to. So we'll start straight away with, what we're doing in this case, in this duologue is actually to present a case which we managed in the recent past. And we use that to bring about the learnings which we want to do for the next half hour. So there would be times when I ask Thomas questions, and there are times when Thomas would ask me questions. And so then we would reach a point where we sort of conclude with each of the areas which are going to be handled. So this was a lady who came to us a few years ago, and she was 44, and she came actually with symptoms of hypertension and palpitations with bilateral flank pain. She also had a history of a thyroidectomy done 22 years ago, and there was a residual or a recurrent swelling in the neck, which was a thyroid, obviously, on clinical examination. So at that point of time, when she underwent her surgery, it was reported as medullary thyroid cancer. She was advised further surgery. She was from up north, but she defaulted her treatment, and she landed up with us when her blood pressure was going out of control. Now, okay, Thomas, I'd like to just ask you, how would you go about this in terms of managing this patient, and what are the highlights you'd like to see happening when you are dealing with such a lady?
So this patient, very clear history, the work you are given, and basically earlier diagnosis of thyroid malignancy, defaulted for completion thyroidectomy, and now patient has got hypertension. So in this setting, in a clinical setting, in OPD, very, very important to get the pedigree chart. We have to draw, or you can get it from the online tool, and the importance of pedigree chart for all the trainees and all of us, very, very important. It takes time, but this gives us a valuable clue for further management, and including screening as well as management. So the pedigree tree.
You could see that this was the patient, and she had two sisters who died. The elder sister expired peripartum due to accelerated hypertension, and another elder sister had died during immediate post-op of a thyroid surgery, and that's very significant. And so unless you picked that up, you wouldn't know. And her mother had a goiter which was not treated, and she had expired. So this was how the tree was. And how would you go proceed next?
Yeah, so we have the clear-cut diagnosis historically itself. We are dealing with a multiple endocrine neoplasia, probably 2A. Probably. So that based on the history. So I'll just go for the relevant examination. You can just go to the, So this is what the importance of anybody who is coming to us with thyroid nodule or thyroid swelling to look at the back, especially youngsters. The very simple examination. It is cutaneous lichen amyloidosis. This is a spotter, and everybody knows this. But in a busy OPD, looking at the back in a person who has got thyroid swelling clenches the diagnosis. This is the cutaneous lichen amyloidosis, and it is seen up to 6 to 34%. That is a very serious. You can get it in multiple endocrine neoplasia type 2A.
Okay, so actually this sort of helped you confirm what you had suspected when you saw hypertension with a residual thyroid. And so this finding, as you just described, was what you said about CLA. But you know what, how do you go further from here? You've got a blood pressure of about 160/100, tachycardia 110. She's got a scar. She's got a left lobe thyroid nodule. She's got multiple, and she was a thin lady with a long neck, and we could actually palpate central neck nodes. And so, which also is a very unique finding. So how would you now go forward in sort of evaluating this lady?
Now we got one segment, medullary thyroid cancer, and we have to go in that line. And also we have got a hypertension, and patient has got a paroxysms. So we are looking at a catecholamine secreting tumor. So we have to look for all the combinants. That's what we are intended to do. So this, if you look at the metanephrin here, it's very clearly, it is elevated more than 2 times. It is definitely, and which clinches the diagnosis of catecholamine secreting tumor in this patient. And can I have the further?
Yes, she also had a red.
Yeah, red testing also was done, because that is one of our protocol nowadays we do, especially when somebody comes at a younger age, we do the red testing and to see further characteristics. You'll come to that.
Yeah, I come to that later. So I'll come. How would you now? I mean, apart from what you said about metanephrines, and you could talk about calcitonin.
So if you see in this panel, we have looked into other components in addition to catecholamine secreting. Of course, calcitonin and CEA both are elevated, which are just giving the same message that we are dealing with medullary thyroid cancer. We also look for primary hyperparathyroidism. So corrected calcium is normal. So there is no hypercalcemia. So this is what we are looking at the overall components. So Deepak, you're going to tell that, when you get this picture, we refer to you. But so from the imaging modality and also from the fine needle aspiration and also with relation to the red testing. So what is our protocol?
Okay, so I think any thyroid nodule has got, you've got a protocol of evaluating that with an ultrasound of the neck. And you can see the solid cystic lesion with the microcalcs in the solid component, which is very suspicious for malignancy. And there are also neck nodes, which you can see lower down in the neck, which are confluent set of nodes with microcalcs in them. So this particular finding is very typical of any malignancy, nothing to do with thyroid cancer, but definitely suspicious for malignancy. So what we did was we went ahead and did an ultrasound guided FNAC of the thyroid nodule. I'll just show you some images which we actually took from this patient. And so you can see polygonal cells with, that characteristic amyloid staining. But what I'd like to highlight to attendees today is that in case you have a clinical finding of actually having a malignancy, but your FNA report is coming as indeterminate, think about doing a calcitonin that may clinch your diagnosis. Because very often you may find that your pathologist has not seen so many MTCs. And if your pathologist is not clued on to this diagnosis, you may actually get your diagnosis with a biochemical proof, which will help you in making your further progress. And so this is again similar cells with that stipple chromatin in it. And we had also went ahead and did the calcitonin IHC on this patient, which was very typical. And this is the amyloid staining, which was there. So I leave that to that, but I drive home the point of the fact that think about doing, if you're getting an indeterminate FNA for some reason and not getting a clue even after discussions, think about just adding on calcitonin to your panel of investigations before you proceed. So what do we do here? Ultrasound is to evaluate the thyroid nodule, but you need to decide based on what the calcitonin level was, and we saw that high level. We have to then decide when do we image with a structural, add additional structural imaging, which is a CT neck, thorax, and abdomen. And this is what we did for her. We have extensive neck disease. That's an indication. When you have signs or symptoms of regional or distant metastases, or even the fact that they've got diarrhea, you can think about adding on structural imaging. But calcitonin above 500 picograms per ml is an indication to say, listen, you need to do more imaging than just the ultrasound. And so we went ahead and did a CT neck, thorax, abdomen, and I'll come to that later. But what we did was also about RET. And Thomas did mention young patients with RET. I would like to sort of add on or reiterate the fact that RET needs to be done for everybody. Even seemingly sporadic MTCs, you will find that those patients are RET positive. Our own experiences, we started in 2008 to do RET testing. We are right now at about 90% of all patients with MTC getting a RET done. In fact, today I have a RET result before I operate on the patient. That's how quick my turnaround time is for the test. We started with the books, what they say of 25%. But when we went on to doing RET on a regular basis, our pickup rate of RET positivity is 32%. So you can see there's a big jump in the patients who are seemingly sporadic, but actually are hereditary. So we need to make sure that RET testing is being done. And if it's not available, centers like us are even accepting samples sent to us by courier EDTA tubes, and we can give you the test result in a 2-week period time. So this is what we went ahead and did. Now, just to talk about RET, a little bit of theory. This was what I like to highlight is the fact that you're looking at 6 exons. You know, exon 10, 11, 13, 14, 16, add on 8, add on 5. That's the whole panel of exons you would test on chromosome 10. And that will give you whether you've got a diagnosis or a suspected mutation in one of the exons. So what we did in this patient, we actually did the screen. We do the whole panel. You could do it, do the 10, 11, and then go 10, 11, and then go to add 13, 14, 15, 16. But it's up to you, up to the lab to decide. So we do the whole panel at one stretch, at one shot. And so this patient had a 634 mutation, which this is the normal, and this is the mutation which was in the 634 codon of exon 11. So we went ahead and then decided to actually go ahead and do the surgery for the pheochromocytoma, which we'll come to now in a while, and then talk about how we went for the how we went about in terms of treatment of the patient. But genetic counseling is for all first-degree relatives with a proven hereditary MTC. So if your index patient is positive, then all the siblings get screened, then the offspring gets screened, and then the parents or the generation above get screened. So you sort of go through the whole rigmarole. And when I was in the center which I trained in Sydney had a family photo of 24 people who were positive from 6 generations who came together to Sydney to take a photograph. I mean, that's how valuable information is when you're talking about screening. And today it's so difficult to actually get screening done, but you can actually work with local people to actually take the blood sample and send it to you, which we do, and get it screened done, tested here, and then tell the family this is what you need to do. So first-degree relatives, patients whose infants or young children have the classic phenotype, or patients with a CLA like how we showed you, or infants with Hirschsprung's disease, and that is for exon 10 mutations. Now, this is what we would normally see, and these are the mutations. So there's a whole set of numbers you have seen here, and puts you off, puts people off, but it's very simple. Remember only 3. Remember 918, which is the highest mutation. Remember 634883, which is a high mutation. The others are all moderate. So if you look at it, that's the highest risk, and this is the high risk, and the rest are all moderate. So if you remember the 3, which is 634, 883, and 918, you've got the rest, because everything else falls in moderate. And that decides on how you go ahead further for in terms of screening. So here we did, the son came to us. She had only one son. The son was negative, but the mother of the son of the sister who died peripartum came to us, and he was 634 positive, presented 1 year later with bilateral pheo and MTC. So the other thing is, when do you, so you have an option, you have some presentations where you could have a pheo first, or a synchronous pheo with a MTC presenting, rather than MTC first and pheo later. So this, the index patient who we are discussing had a MTC first followed by a pheo which presented later. Whereas this boy has come to us with a synchronous presentation of both MTC and pheo. And so the indications for RET testing, as I just told you, was what we just mentioned. But what I'd like to highlight is, in the patients who've got, when you're screening family members, if you have a kindred, and if the kindred's presentation is about, let us say, 25 years, you start screening at 10 years below that. So at age 15, you can start screening, if you don't have the option of screening them at exactly the age which the guidelines say. So that's one sort of guide to say, listen, your youngest patient in your kindred is 25, start screening 10 years prior to that, which is 15. So, you know, as an example. So that's about, once you've detected that, when do you do the screen, or when do you do the surgery for the screen detected family members? So in the highest risk, it's in the first year. or as early as possible. But obviously best done in centers where you are dealing with such patients, and it is best not handled in a center which does not deal with such patients frequently. Then 634 and 883, this has undergone a lot of change. It's at 5 years or earlier based on, again, on the calcitonin level, but all the others, you can actually wait. You can wait for the calcitonin to start rising, or you could add that with an ultrasound which picks up a thyroid nodule and then decide to consider an intervention. So the point here is in only the 634, 883 and the 918 are we truly doing a prophylactic thyroidectomy. Others, you're waiting for a biochemical proof coming in and then you kick in with surgery. Okay, I think, Thomas, I've done a lot of talking. I must say that this patient obviously had bilateral FEO. I think just for completion's sake, we went ahead and did a bilateral adrenalectomy. But before that, Thomas, you would like to briefly talk about.
See, the one point, as Deepak mentioned, we do, that is our protocol for quite a number of years, that do genetics for all people who are coming with MTC. And here we had a clinical clue that patient had a cutaneous like an amyloidosis, which is pointing probably towards 634, which that's what we found. And here we found that there is a catecholamine secreting tumors on both sides. So they have to be knocked out before we handle MTC. So adequate preparation and handling pheochromocytoma surgically before we tackle MTC. So
she underwent a bilateral retroperitoneoscopic adrenalectomy in the same sitting. We did cortical sparing on the side which had a smaller tumor. There was the highest blood pressure surge while on table even after blockade, and which was followed by the classical post-op hypotension which required inotropes. But in sometimes these dopamine secreting tumors, you will never have the surge. You may have patients who actually do not have that much of a normotensive in those groups. So be careful, be wary of the fact that you could have a tumor which does not secrete adrenal or metanephrines. Okay, the other thing about how do we approach MTC? So we'll come to what is our topic today, is that this is again a rough guideline. So when you have calcitonins which are above 500, you've got metastatic disease outside of the neck. If you've got something between 200 or up to, in the range of 200 to 500, you've got disease in bilateral neck. And you've got less than that, it is confined to more of the central neck. And, that is I'm just telling you that this is a guide. Today, I saw a patient in the OPD with a calcitonin of 25,000, no neck nodes, but has got bilateral adrenal mets. So just to say that, the disease is truly may skip lymph nodal metastasis and go straight to hematogenous metastasis. And so beware of that. And so these are rough guides to keep you going and to say, make sure you've covered all your bases before you actually tackle the patient's thyroidectomy. Okay, go ahead. So she underwent completion thyroidectomy, central neck dissection, and a bilateral lateral neck dissection. So that's what we did for this patient, even though, after the FEO was done. So it was a week later. And so this is what the results were 3 months after we saw her.
Yeah, we can see here, we have a serial calcitonin, of course, CA also. Some of the DM trainees know that last 4 years, we have CA 19.9 also, which is done to indicate, there are literature to indicate the poor prognosis if it's CA 19.9 is positive. In addition to these, so how do you, when we look at calcitonin and we have this specific, we can have a calculator, calcitonin doubling time. So we enter the serial calcitonin as per the months or years and look at what is the doubling time. If the doubling time is less than 6 months, it is going to be, we are going to deal with aggressive tumor. If the doubling time is approximately more than 2 years, it's fairly indolent. And if anything, it is in between 6 months to 2 years, we are just say it is an intermediate severity. So, Deepak, yeah.
So this patient had a 9.73 months of doubling. So which is basically closer to the 6. So you've got more aggressive disease. But what I'd like to highlight is actually through the previous slide, where you saw that this surgery did not budge her calcitonins. You see, pre-op it was 9,986. Post-op, after surgery in September, it was 4,760. So you see that even though your surgery is done, you have not actually done anything to calcitonin. But what has happened is you are opened up an option to actually decide further down the line what you could do, and again decides when next surgery needs to be done. And you have not to balance between metastatic disease causing death or locoregional disease causing airway problems. So you need to decide that. That's going to make your call. So this patient actually points towards more systemic disease. But we went ahead to operate primarily because the neck was operable and we could clear the disease from the neck. But we went on when we saw this, the calcitonin doubling time showing closer to being a disease which is more aggressive, then decided, listen, we can't leave her here. We can't just stop. We have to continue further treatment and options of treatment. So what do you say, Thomas? What do you do next?
Yeah, so this setting definitely, as you said, in addition to surgery, we have to look for adjuvant therapy. So we have, we can say about the isotope or chemo or both. That's what we are looking at. Can you tell about the isotope?
So what we offered this lady and the family was to start with MIBG therapy, which is one, it is within reach of the patient's pocket. No, it was not as expensive as lutetium. So we went ahead and did an MIBG therapy. And the good thing for her was the MIBG scan was positive. So obviously you can only treat if your MIBG scan is positive. So we went ahead and gave her 2 sittings of MIBG. She actually went, if I'm not mistaken, after the initial scan, went to BARC in Mumbai to get the therapy because it's cheaper than getting it done in Vellore. So she went ahead and did that. But this was her showing the uptake in the liver. And the other option is to actually consider a PRRT, which is lutetium, and that is just for completion's sake. And we did not do this in this patient. Primarily, our experience with lutetium has been very, very, let me at best put it, on the fence. It's not great, but it is an option to keep. So you need to get a DOTA PET, and the DOTA PET, if positive, you can use lutetium as a therapeutic agent. So when to use a DOTA versus when to use an FDG PET. FDG PET is more for prognosis, and if you've got an FDG positive disease, again, it's like an aggressive disease. It is pointing towards aggressiveness of the disease, but it is not giving you an option for therapy. A DOTA is going to give you a therapeutic option where you can actually bring in lutetium if your DOTA is positive. And so that's something which you could do, and you could, what's considered as, minimum of 4 doses are administered once in 2 months, which pretty much is 1.5 lakhs something per dose. So you can see how much that it costs for a patient to undergo PRRT with lutetium. So, okay, Thomas, you want to make some comments now?
Yeah, so here, because of the cost effectiveness and MIBG positivity, we went with MIBG therapy. Of course, as Dr. Deepak said, in a selected setting, we go for PRRT. Of course, the cost is a main constraint. And you want to add on, towards the end, like a systemic therapy.
So systemic therapy is when you reach the end of the road. Systemic therapy is not for every patient. A systemic therapy is for progressive, non-resectable, symptomatic disease. And if you get that in your algorithm of workup, then you know that you've got to sort of consider systemic therapy. Just because calcitonin is increasing, you don't need to actually offer them any TKI. We've had patients with calcitonin who have doubled over 10 to 15 years and are calcitonin sitting at 20,000, their only symptom being diarrhea. They're okay to manage with loperamide. You don't have to offer them systemic therapy because the scan is not picking up any disease. No structural disease is demonstrable, but calcitonin is high. They've got diarrhea, and this hypercalcitonemia is a biochemical entity and not a clinical problem. Right? So this patient, we went ahead because of progressive liver mets and which was causing symptoms. And hence we decided, okay, what do we do next? So what we are going to say is, what is standard care is vandatinib and cabozantinib. Vandatinib, we were part of the trial when it was Zactima, when it was first brought into our country in 2005 and 6, when we enrolled 4 patients into the trial. And today, those patients are still getting vandatinib and are alive. That is now 25 years later. So, I mean, I'm just saying, you need to get a passion to treat these patients, and to see them alive at this point of time, where otherwise they would have been dead, makes life worth living. You know, and so this patients had a beautiful, had a good opportunity to get onto these trials when the drug was not available in this country. Today, vandatinib is available as a generic form, not too expensive, and you can get it within reach of many patients who can afford it. So, but what I'd like to bring about is, what are the newer drugs? Selpercatinib was Libretto trial or the Loxo trial or Atezvo. These are the various trade names which the companies had used. And so you can see that the overall response rate is about 71%. And these patients benefit in RET mutation positive. So even if you've got a sporadic MTC, you can test the somatic mutation. And if the somatic mutation is positive for RET, you can offer them this treatment. So we had a patient who recently was sporadic MTC, 40,000 at the start, came down to around 200 and odd on vandatinib for some time, then started rising. So we took the tumor from the original specimen, did a sporadic or somatic mutation on it, RET positive, offered them pralsetinib, and this was being given on compassionate care by the company, on grounds by the company. And so that patient right now is on pralsetinib to reduce the burden of disease. So this response rate is where we are seeing, and you can see about 74% of overall response rate. Okay, so you want to say something?
Yeah, so I think you highlighted the point of looking at a somatic mutation. That also will add value to your deciding the therapy, especially with relation to chemo, especially RET specific. That's a very valid point. We always look at a germline. Of course, for last 7 to 8 years, we also getting into more treatment specific with relation to tumor specific mutation, especially somatic mutation.
So we are doing a thyroid panel which is available commercially through MedGenome or many other labs, where you could actually do a whole panel of genes. Then you can do specific targeted therapies in these patients. So the one I just mentioned this is a patient who actually got vandatinib, and you can see the panel on the left is where the tumor was very bright, and you can see this sort of regressing, and you can see each of those. These is post-vandatinib, pre-vandatinib, that you can see how the images are showing that how this is given as a neoadjuvant setting. So this is our own experience of dealing patients with very aggressive disease at the start, not wanting to operate and do an R2 resection and leave behind gross disease. Go ahead and give them neoadjuvant options, reduce the tumor burden, and also you can see that this is pre-op and this is pre-vandatinib and this is post-vandatinib 3 months. So we went ahead and you can see the difference between this panel of same images which were picked up at the end of 3 months of TKIs. And you can see that we went back and operated on this gentleman, took out the disease from the mediastinum, took out the disease from the neck, and we got that much disease out. And there was almost an R0 resection. It was maybe definitely not R2. We have not left behind gross disease. And show next. And you can see that this calcitonin at 46,800 post vandatinib after 3 months of therapy came down to 9,974. And then in January 2019, we continued vantertenib post-op, went down to 224, and he was going on that. And then October 2021, he came during during lockdown, and you can see his calcitonin had started climbing. So we then did the red testing on his tumor, which I mentioned, and we got him to get on to the newer red specific TKIs, which is now, he hasn't come back for his follow-up. And hopefully in the next month or so, we'll see him here and repeat that this thing to see how it will go. So he's on selpercatinib as targeted therapy. Okay, that's it. Thank you so much. I think we'll end here. Any questions, we are happy to take.
Thank you so much.
Thanks very much. It's a real spell one. Wonderful effort of Thyroid Clinic. Thank you very much, madam, for giving us an opportunity. I think I wanted to ask you a question, but let's take the audience thing. Can you see, Deepak and Thomas, the question? Dr. Ahmed is asking, do structural imaging be complemented with functional imaging in the staging extent of disease or diagnosis? And also, he asked for how do we look for somatic mutation?
Okay, I'll answer. I could see the second question. It's easy. So when you have the original paraffin block of the tumor, you can on the tumor get a red test done, right? And it is just similar like how you do the germline. So you do the red testing on the tumor, and that becomes your somatic mutations, which you are testing. And if it is positive for the red testing on the tumor, even though not reflected in the blood, can be used to target the tumor with red specific agents. What is the other question? I didn't get the. I didn't see the question.
Do structural imaging be complemented with functional imaging?
Yeah.
For the staging and extent of the disease or diagnosis?
At diagnosis, we generally don't use functional imaging. We use structural imaging for diagnosis. Your functional status is decided by calcitonin. So why do a functional imaging? You know, your burden of disease is sort of very graded by your calcitonin levels. And here you can see the CA was 500. So you've got an aggressive start. You know, you've got a dedifferentiating tumor from the beginning. If you had a CA of 25 and a calcitonin of 15,000, you have a better prognosis than 15,000 and a CA of 500. So you don't need a functional imaging to actually complement your structural imaging as you require for a patient with, let us say, parathyroid for localization.
And there's another question from Dr. Harshita, that what is the response rate with MIBG versus lithium therapy?
Okay, we should have had our nuclear physicians on board. Then you have to label it not as a duologue but a triologue. But the point is, I think our experience, that our own institutional experience with MIBG has been fairly good. And when lutetium came on board, we started using lutetium. But as I said along the way, it has not has been that great as what the textbooks describe or what the literature describes. What is the exact rate? I'll put a ballpark figure. I'm subject to correction. Maybe my MIBG positivity is close to about 50 to 60%. Lutetium is about 40 to 50%. But I'm willing to be corrected. Yeah.
Can I ask you one question? See, you told it is pretty aggressive because the doubling time is 9 months, but this lady was good for 20 years.
Yeah. So
it's very surprising.
No, the point is, you may find that the CA rising was the indication to say that tumor is becoming dedifferentiated. If we had a calcitonin and a CA at the beginning and then compared it now, we would have got that picture. But my educated guess is that the CA started rising when she presented now. But actually she presented not because of the CA, she presented because of a FIO. That's what brought her to hospital. If she had not got the FIO, she would have stayed at home. And she would not have possibly ever come to us.
One more question is that we will answer. Should we check calcitonin levels in all thyroid nodules?
No, I think I made that point very clear. It's only for indeterminate FNAs. When you have a clinical picture which is very, very positive or very, very strongly suggestive of being malignant. So I wouldn't say that we should use calcitonin as a regular tool for a thyroid nodule assessment. I'm sure there'll be difference of opinion, but within the group, but I am backed by the ATA.
Dr. Banisri is asking insights on post-op imaging protocol after surgery.
Yeah, okay. Yeah, so good question. What we do is we call them at 3 months, check only calcitonin and a CA at that point of time. Don't bring in imaging, right? But you compare with your pre-op calcitonin CA, which will then tell you how much of disease burden has come down. After that, you call them back in 6 months. If your calcitonin is roughly the same value as your immediate post-op or the 3-month post-op, don't do anything, keep going. So we may find that calcitonin increment increase may be only 100 and 200, but don't jump into imaging immediately. Just continue with biochemical screen, and you reach a point, okay, you come back later, we'll see you in 6 months. And then when you see a significant jump, you know that that's the time when you bring in structural imaging. So the structural imaging comes in only in the situation where you are thinking that the disease is actually doubling fast. And then if you can use this calcitonin doubling time calculator, it will help you strengthen your decision. Now, the point is the calcitonin doubling time calculator was free. It was available online, but today it's gone offline. It's gone into, you have to have ATA membership to get the calcitonin doubling time calculator. It's not available free. It says when you go to the website today, it says it's under maintenance. So it's not available for us. So what we do is actually we just put down the values and calculate ourselves to give you a rough idea how many months it is doubling at. So these are points which I would say that, so we decide on structural imaging in our MDTs to decide when to go with adding on to the biochemical screen.
Any quick comment from the panelists, Dr. Odun, Dr. Prakash, Madam Sharita?
Yes, it was a nice presentation, and most of the things were well covered, and how to approach, how to go for surgery, then post-operatively, then systemic anti-RET therapy, and many other things. Can we, Dr. Deepak, can we go for a PET scanning instead of these MIBG or something? Here we some
PET.
Yeah, so as I told you, the PET is it's a dead end. PET is not giving you an option for further therapeutics.
Right.
For the FDG PET.
FDG PET.
Not the DOTA PET, the FDG PET. Now, in FDG PET positivity in MTC is showing you an aggressive tumor. A DOTA PET positivity in MTC is showing you an option of giving lutetium.
Very nice.
So there is a therapeutic angle to a DOTA scan. There is a prognostic angle to the FDG.
FDG.
So use those two tools to decide how you want to go.
So it is better to go for the MIBG.
Yeah, I mean, MIBG is, see, I'm not advocating MIBG for it. I mean, that is one option which is available for us. If you can consider that and patient cannot afford to go for lutetium, this is an option. And this patient actually was positive. And she got, if I'm not mistaken, even more than 2 or 3 sittings of having lutetium, of having MIBG, because she couldn't even afford to take which costs about 40,000 in Vellore to do an MIBG therapy. She went to Bombay to get it done, which she got it free.
And I will like to give a comment that it was a really very informative dialogue and made many of the things clear to us. And many of the times what we get patients with the MTC, we usually do not have them follow for a very long time. And usually they escape, or so we are not able to do that much in our centers here. But we learned a lot, and it must have been informative for all of us. Thank you, Dr. Paul, Dr. Deepak, and Dr. Pandev for conducting nice session. And now we can move for the second session. And now back to
Thanks very much. Yes, madam, comment.
Yeah, I think this is absolutely like Arpan, I will echo what you said, spellbinding. And I think you make such a wonderful team. And the presentation, I think it's a wonderful learning experience. I cannot thank you enough. And I want you to promise to be back again for another thyroid clinic. I think we're really, it would be lovely to have you. And like I said in the beginning, both of you are legends. And Dr. Deepak, thank you. Thank you so much for both of you for being with us.
Thanks very much,
Thank
Thomas
you.
and Deepak. We think we'll move it toward Om is eagerly waiting now for quiz time with Evergreen Om Lakhani from Ahmedabad.
Thank you, sir. So, can I be allowed to share my screen? Yeah, so if the technical team is good to go, we'll be starting the quiz. Yeah. So,
yes, sir. Yes, sir. I started launch the poll.
Yeah. Okay. So the participants, you'll get the question flashed on your the options flashed on your screen, and you have about 15 seconds to answer each of the questions.
Yeah.
There are 20 questions right now, and I'll be quickly going through these questions. So I'll start with the first question. Just to give you a theme, the only theme I've tried to keep is that I've tried to include some recent topics and some ancient topics, right? So we'll be dealing with history and alternatively extremely recent stuff, published very recently in the journal. So that's how we are going to go about it. That's the only theme we are going to look at. Okay, so if you're ready, we'll start.
Yes, sir. Just a second. I'll launch the poll.
Yeah. So it will take me a while to read the first question. So I think I'll go ahead with the first question. Now,
Yes,
it's a serendipity, I would say, or it's irony that the first question is about an endocrine surgeon and an endocrine physician. It's a long question, but we just had a duologue with an endocrine surgeon and endocrine physician. But contrary to them, these two were not very. These two were not very friendly. So this is a little bit of a story here. So we have some relay. You could say. Yeah, so this is okay. So this is the story of the surgeon and a physician, and the physician here was Edwin Atwood, who first was the inventor of propylthiouracil, and in this very famous interaction with the surgeon, the surgeon called this physician as Mr. Poor Dr. Atwood, and he said that ultimate treatment of Graves' disease should be surgery. And his response was, poor was thought in a bad light because at that point of time, the physicians were really poor and the surgeons were doing pretty well. In response, Dr. Atwood gave a rousing argument in favor of medical therapy, and the treatment of Graves' disease has never been same again after this speech by Dr. Atwood. And in his mic drop moment, after he ended his talk, the poor doctor signaled the end of surgical treatment for Graves' disease, not totally, but partially to a lot of extent. But what I want to know is who is this rich but poor surgeon who took on Dr. Atwood? So the options here are: was it Emil Cocker? Was it Pierre Joseph Desol? Was he Frank Lahaye, or was it Earl Chapman? So you have the question being flashed on the screen of the poll.
Yes, sir. The question is only seen for the attendees.
Yeah. Okay. We'll move to the second question now. Okay. So based on a recent study which was published in Journal of Endocrinology and Metabolism, and since we are going to have a talk on thyroid nodule, this is very relevant. It's a very recent article. Which of the following is associated with higher risk of malignancy? Does an oval-shaped nodule associated with more risk of malignancy? Is a sphere-shaped associated with more risk of malignancy? Is a pear-shaped nodule associated with risk of malignancy? Or there was no correlation between the shape of the nodule and risk of malignancy? So what you're looking here is the shape of the nodule, right? And not the the dimensions. I'm not talking about the width and the taller than wider, wider than taller. We're not talking about that. We're talking about the shape of the nodule. So does the shape correlate with the risk of malignancy? And we have Dr. Krishna Shisaji's sir's talk next. So I think, perhaps, this is something which is relevant to today's talk. Okay. Moving on to the third question. So this is a case of a 30-year-old primary gravida. This is a case here. She has a TSH of 4.1. And in her first trimester, it was done as a routine screening. Her anti-TPO antibody is positive. However, there is no prior history of first trimester abortion. There's no history of abortion at all. This is, first gravida, first para. What should be the approach to this patient? So this is a TSH of 4.1. Anti-TPO is positive, but no prior history of abortion. So based on the current guidelines, would you start this patient on levothyroxine? Would you get an anti-TG antibody done? Would you wait and watch and repeat the thyroid function after a month? Or would you start the patient on selenium supplementation, however, not on levothyroxine? So what would be your option for this patient?
1 minute. I think some people are finding difficult how to answer. If you can just tell again.
Yes. So,
yeah.
Can
you repeat that? Yeah.
Yeah, we have the poll up. So if you see, there's a polls and quizzes option on the top. And when you go through this, you will have the questions, which is flashed on the screen. The question is a multiple choice question. You will, it will be like a pop-up which shows up on the screen. It should be visible to all. It's not visible to the host and the panelists. It will only be visible to the participants. But somehow I can also see it. So if you are not able to, you can, there's a polls and quizzes option on the top when you see.
They're saying pop-up is not coming.
Ma'am, it might not come for the panelists. It should come for the the technical team. Can we get a help with that?
Asmita?
Yes, ma'am.
Pop-up is not coming. There's so many messages. Bharti is messaging, Pankaj is messaging, pop-up is not coming. Can you please check? Go to more with the dots. Somebody is replying. Dr. Shyam Sundar, CM.
Yeah. So, if, there will be something like a polls and quizzes.
Ma'am, they need, hello?
Yeah, please go ahead.
They need to click on the poll options and scroll the poll. Scroll the screen.
No, I think many of them are trying to do it on a phone. So you need to get the phone installed.
Yeah.
So if it's possible, we can move to plan B because we have a plan B also for this.
Oh, good for you. It's not because somebody is desperate to answer the questions.
Okay.
I think please let's do plan B. I think
okay.
Do you agree, Arpan? I'm sorry to interrupt.
I think because if they cannot answer, it will be difficult.
Yeah. So here's
I'm happy that people are interested.
Yeah, great. So okay. So here is plan B. So I'm putting the link to the quiz. So this will open a form on a separate page. You will have all the questions and the options. So I would suggest that to everyone, even those who could answer through the poll here, please go and answer on the other form so that we'll have a sort of a correlation here. I'll post this link. You have the QR code. I'll just So you have the QR code on the thing. You can use the QR code to open the link. I'm also sharing the link on the chat. So a second. Yeah, so I've shared the link on the chat. You can open the link and you will find the quiz. You need to enter your name, your email address, your city and phone number, and then you'll get all the same questions again on the link. So I hope you could answer through the link as well.
Om, the great IT person.
So I mean, this was plan B, so I hope it works for us. Yeah. Okay, so I think we will move on to the question. I'll go a little slow because I believe that there are a lot of people who might take a little while. So I'll go a little slow here, but I'll continue the quiz nonetheless. So we'll go to the fourth question. This is again a little longish one. So we have George Murray. was credited with discovering the treatment of mixed edema. He injected sheep extracts to cure the disease. However, though successful, he was not the first person to propose this treatment for endocrinology. The credit for this also goes to what is known as an organotherapy, which goes to an eccentric French doctor who used the same treatment often unsuccessfully in various endocrine diseases, including adrenal insufficiency and male hypogonadism. So what you need to tell me is, who is this mad Frenchman? Well, not mad, little, weird, you can say, but he actually started the, actual treatment for endocrine disorders. And the thing is, the hint here is, he has made a very important contribution to endocrinology. He's actually very famous for a neurological disorder, which is named after him, right? So you need to answer this. So is it Alois Alzheimer? Is it Dr. James Parkinson? Is it Dr. Gordon Morgan Holmes? Or is it Charles Eckhart Brown-Séquard? So remember,
yeah, I think we need a hint for your hint to because all four will have a neurological disorder. That's the great hint.
So you have, and a couple of them are, I think, Frenchmen. So I think
there's only one French name there. Huh?
That will be the clue.
So that's the other hint. Okay. So moving on, we have the fifth question. There's a new study published in New England Journal of Medicine called the Estimbal study. So NEJM, I hope everybody is reading. So this compared the 3-year outcomes of patients who underwent radioactive iodine therapy versus no RAIT in patients with low risk thyroid cancer, right? So low grade thyroid cancer. And what was the conclusion of this study? So they compared RAIT versus no routine RAIT. So was it the use of RAIT was superior compared to no RAIT? Was the use of no RAIT superior to RAIT? Or was the use of no RAIT non-inferior to RAIT? Or none of the above? Now remember, there is some play in words, right? Is it superior? Is it non-inferior? Is one better than the other? Is the other better than the first? Right? So you need to be aware of this. And like I said, this is a study published in New England Journal of Medicine recently. Of course, we'll be discussing the answers right after this. So we'll be locking the quiz after that. So, okay. Moving on to the sixth question. So very interesting question, okay? So are thyroid hormones, LT3 and LT4, amongst the list of prohibited substances according to World Anti-Doping Agency on elite sports? This is something we should know, right? Endocrinologists are often, of course, we don't directly take part in this, but we have to know this. So is LT3 banned? That is, LT3 banned, but LT4 is allowed. Is it neither LT3 or LT4 are amongst the list of prohibited substances? So technically both are allowed. Is LT4 banned, but LT3 is allowed? Or is it both LT3 and LT4 are banned and neither is allowed in elite sports? So the question here is, if you're hypothyroid, can you take part in elite sports, right? That's the question, right? That's interestingly, and perhaps, somebody would kind of hack the system by taking LT3, instead of levothyroxine. Okay. Moving on. So we have a 20-year-old male who presents with generalized weakness and skin darkening. Now, on evaluation, this patient was found to have a TSH of 12. An anti-TPO antibody was positive with a normal free TPO. Now, a morning 8 a.m. cortisol was sent, which was 1.2, right? What is the next step in management of this patient? So you have this patient who is, you can see the clinical profile here. Would you start this patient directly on levothyroxine, the dose of 25 to 50 microgram? Would you start this patient on glucocorticoids followed by levothyroxine? Would you start this patient on glucocorticoids only? Or would you say no treatment is required at this point of time, and would you wait and watch? And we'll of course take opinions of the experts when we discuss these answers as well. So, we'll love to hear the opinion, because I think some of these might be a little bit controversial as well. But we'll weigh the evidence. Moving on, right now. So this is a study which was done from, we had a talk today from CMC Vellore. So it's a study done from CMC Vellore, which actually they reassessed the TSH cutoff for newborn thyroid screening using cord blood, right? So you use cord blood for screening. So what TSH, according to their study, was optimal? Now, why I put this question, though it's a recent evidence, they have been using this cutoff. So those who have worked with CMC below would know this, and they also published this several times in many guidelines as well. So is it more than 20? Is it more than 25? Is it more than 30? Or is it more than 40? So what cutoff was used for this newborn thyroid screening using cord blood? Okay, remember it's cord blood. Okay. Next, so a patient with a CNS tumor is on high dose of dexamethasone for the last 7 days, and you have been called to assess the patient's thyroid function. So the patient has a TSH which is low with a low free T3 and normal free T4. What is the diagnosis? Now, a lot of endocrine people would know the answer, I think, straight away, but this is a pan quiz for also open for a large variety of other specialties. We're trying to, ITS is open for, physicians and other specialties as well, family doctors as well. So I think, it will be helpful. So is this patient having central hypothyroidism? Is this patient having destructive thyroiditis caused by dexamethasone? Is this patient having thyroid dysfunction secondary to dexamethasone therapy or something of non-thyroid illness? Or is this just a lab anomaly? So remember, this patient is having low T3, normal T4, and low TSH. Okay, moving on. So we are at the halfway mark, and another question from history. So this is the first woman to receive the Nobel Prize in Medicine and Physiology, was Gertie Corey, after whom the Corey cycle is named. Again, proud to have endocrine association there. Now, the second woman to receive the Nobel Prize in the same category made a key contribution to the field of thyroidology. Her first name was Rosalind, and Rosalind won her Nobel Prize in 1977. What was her contribution to the field of thyroidology? I'm asking about thyroidology specifically. Was she the first to discover the role of iodine in the thyroid gland? Did she devise the radioimmunoassay for assaying thyroid hormones and other hormones? Was she a person who invented radioactive iodine therapy for thyrotoxicosis? Or what is known as Rosalind Graves, and the name is enough. So it's a Rosalind, it's a pretty famous Rosalind, and we know her contribution to endocrinology in general, but what's the contribution to thyroidology? Moving on. So again, a recent study which was published in JCEM, where they used a parameter which was associated with highest risk of post-operative vocal cord paralysis in a patient who was operated for a benign goiter. So what was the parameter which led to, saying that the risk of vocal cord paralysis is more? We also have the endocrine surgeon today. So is it experience of the surgeon? Was it a pre-operative TSH level which determined? Was it the weight of the thyroid specimen? Or was it the weight of the patient? Right? What was the reason? What led to higher risk of post-operative vocal cord paralysis? Recent paper, again, if you open JCEM recently, you might find this interesting article. Moving on. Okay, so we have, according to a recent study which was published by Dr. Pramila Kalra, ma'am, she's there today, in Thyroid Research and Practice, which is the flagship journal of Indian Thyroid Society. What is the approximate prevalence of permanent hypothyroidism following an episode of subacute thyroiditis in the Indian population at the end of 1 year of follow-up? Okay, so is it close to 10%? Is it close to 20%? Is it close to 50%? Is it close to 90%? So I'm talking about subacute thyroiditis and subsequently hypothyroidism. So what is the prevalence of permanent hypothyroidism following a bout of destructive thyroiditis? So everyone except the authors are allowed to participate in this answer. Okay. Moving on to question number 30, another recent article. So there's a new study which was published in JCEM, which actually found a very interesting correlation between what is known as fluid intelligence and TSH level in euthyroid men and women. So fluid intelligence is your ability to take the data and use the data to solve a problem. So it's basically ability to solve new problems, which was based on previously acquired knowledge. According to the study, what is the correlation between the TSH level within the euthyroid range and fluid intelligence? So was it that a lower TSH was associated with higher fluid intelligence in both men and women? Was it higher TSH which was associated with higher fluid intelligence in women? Was higher TSH associated with higher fluid intelligence in both men and women, or was lower TSH associated with higher fluid intelligence in men, but not in women? I know it's a little different, confusing question, but perhaps if you read this paper, you again find the answer. And this, let me give you a hint. This will question your belief about TSH within euthyroid range probing. That's the hint. Okay, so according to a new study published in Thyroid Research and Practice, again, I think Dr. Kalra is the author here. What is the impact of metformin on TSH in women with PCOS, right? Okay, so is it metformin reduces the TSH in all women with PCOS? Does metformin reduce TSH in women with PCOS having pre-existing thyroid dysfunction, but no impact on those with normal thyroid function? Was it metformin reduces TSH in women with PCOS not having pre-existing thyroid function, but no impact on those with abnormal thyroid function? Or is it metformin has no impact at all on TSH? Very interesting study. Moving on. So again, this is something which endocrinology residents should be able to track. So what is the ratio of free T3 by free T4 in picomoles by picomoles, which gives 70% sensitivity for differentiating Graves' disease from destructive thyroiditis in patients presenting with thyrotoxicosis? So, when a patient comes with thyrotoxicosis, you want to differentiate between Graves versus subacute thyroiditis or destructive thyroiditis. So what ratio helps you? T3 to T4, free T3 to free T4. Is it less than 0.2? Is it more than 20? Is it more than 0.3? Or is it less than 30? Right. So if you read this question carefully, you'll get your answer. It's very simple. It's unnecessarily made complex by me. Right. It's very simple. Okay. Moving on. Does any form of thyroid hormone metabolism polymorphism has any protective or negative impact on patients with COVID-19 infection? This is again a JCEM recent study. So is it thyroid metabolism has no correlation with COVID-19 mortality? Does a specific polymorphism in type 1 deiodinase associated with increased risk in in-hospital COVID-19 mortality? Was a specific polymorphism in type 3 deiodinase associated with mortality, or was it a specific polymorphism in type 2 deiodinase associated with mortality? And it's a tough question again, but I think it perhaps would make you go and read this paper, which is very interesting paper. Okay. Moving on, a recent study published in IJEM studied the various cytopathological features for diagnosis of papillary thyroid carcinoma. Again, we have a talk on this. According to the study, which of the following is the most sensitive parameter for diagnosis of PTC? Was it Samoa bodies? Was it giant cell macrophages? Was it intranuclear cytoplasmic inclusions? Or was it papillary cores and nuclear grooving? Which is the most sensitive of these histopathological cytopathological Moving on, a recent study, very interesting study published from Bangladesh, our neighbors. It was published in Thyroid Research and Practice. They found a unique correlation between a chronic heavy metal toxicity and increased prevalence of thyroid disorder in their population. What was this heavy metal in question? Was it selenium? Was it arsenic? Was it lead? Or was it mercury? Again, it's a metal. That's a hint. Okay. Now, I added this question because we're going to talk about MEN, but this, of course, has very little relation with thyroid. But that MEN4 is associated with which genetic mutation? Is it RET? Is it BARD1? Is it CDKN1P? CDKN1P, or is it Epstein? So which gene is associated with MEN4? We're not talking about MEN1, not more about MEN2, which we discussed a little bit about MEN2 today. We're discussing about MEN4. I am now moving to the last question. So, a 25-year-old female presents with multinodular goiter. Her thyroid function test is suggestive of low TSH with normal free T3 and free T4. what is the next step for this patient? Okay, again, endocrinologists would know this. This is open for all though. So 25-year-old with multinodular goiter, she has a low TSH with normal free T3 and normal free T4. So would you do a USG guided FNSE from a thyroid nodule or a dominant nodule here? Would you do a technetium thyroid scan and FNSE from a cold nodule? Would you refer this patient directly for surgery? Or do you start this patient on carbimazole? Okay, so you have a few seconds to submit your answer. So please submit the form in the end. Now, currently, we are at the time of 9:11. Any form which is submitted after 9:11, the time is very easy to remember. So anything submitted after 9:11 or 9:12, we will not be considering because remember, we'll now be discussing the answers.
Can I just interrupt for a minute? I need the permission of Madam. What do we do now? Should we discuss the answer or should we keep the quiz for the next clinic?
No. We're having the talk now.
Okay.
The answers will come after the talk is over.
Okay, that's
Please
fine.
go ahead. Please go ahead with the talk. Dr. Krishna, I'm sorry for the delay. Thank you for bearing with us.
Okay, so we'll move over to the last portion, which will be very interesting, as charismatic as Bhagavan Sri Krishna. Krish Seshadri, where are you? I can't see you.
He's there.
Where is Krish?
He's there, very much there. Thank you. Thank you for bearing with us.
Yes, Krishna, I can see you.
You're
Krish,
not-
all yours.
You're
Sorry,
not going to discuss the answers or?
Later, after you finish.
Okay. Well, I guess that ensures that we have a couple of people.
Yes, positively.
Can you allow me screen sharing, please?
We'd request the chairperson to introduce the speaker, then we can go to the speaker
I
slides.
think it will be very embarrassing to introduce Krish Seshadri. No, it's all Krish Seshadri. Everybody knows Krish Seshadri. Krish, please carry on.
Please go ahead. Please go ahead.
We all know
Thank you, Arpan.
Please allow, yes, thank you. Please allow screen sharing. 1 second. Let me figure out
Yes,
which.
sir, that's allowed. You can share your screen.
Sorry, I'm just, I was reading as I was listening to Om. Om, thank you very much. The most important thank you is I realized that at least one person in the world is reading the
TRC, Thyroid Research and Practice.
ITS journal. Right?
Yes, thank you.
In fact, the Bangladesh article was very, very nice, and I thought, I'm glad to see it this thing. So from the beautiful, enigmatic, and wondrous world of medical MTCs, and Om's world of quizzes and paradoxes, I'm going to give you this very boring nuts and bolts talk. Okay, why? Because it is a nuts and bolts talk because I think, and in fact I told Dr. Bajaj that I'd be very happy to give this talk because it's something I'm very passionate about. I can see Prasanna somewhere here, the man who pushed me into nodules in many ways, but I've been involved with nodules from '98, and I think this is something that every one of us should at least learn to do in a reasonable way. So the ACR Thyroids is the American College of Radiology's Thyroids, and I think it's one of the best ways to provide guidance to the management of thyroid nodules to most of us. You're free to take screenshots. I'm quite happy with that. So this is from the IJEM, that is, and I'm plugging my own algorithm. So basically, a clinical exam, TSH, the ultrasound, whether it meets criteria for FNAC, and if you meet the criteria for FNAC, then you do the FNAC. So this is the big picture. I'm happy to do a talk on indeterminate thyroid nodules anytime, sometime in the future. But let's talk about this. This is a beginning of this. This is 2002, Kim et al., American Journal of Radiology in 2002. And they identified these points: microcalcification, irregular or microlobulated margin, marked hypogenicity, more taller than wider. In fact, I won't give you the right answer for that JCE question. But if you notice it, that any of these having present had a high positive predictive value, but more importantly, not having these had a very reasonable negative predictive value with an accuracy that was in the 70s at that point of time. Subsequently, different variations of the TIRADS, the K TIRADS, the European TIRADS, the Americans, of course, not left behind. All these TIRADS came. And then, of course, and this is our work that initially started. Many of the things was published 2 or 3. I mean, we had several abstracts, the last one being 2018. Again, the JCE showing the big correlation between the TIRAD score. This is the original TIRADs, not the ACR TIRADs, and the Bethesda rating. And if you had a TIRADs 2, then it is nearly impossible to see rating more than just one Bethesda 1 in this whole thing. Most of these are Bethesda 2. And in fact, we've come to a point where if it is TIRADs 2, people would say there's no need for an FNAC. The ATA, not to be left behind, came with their own score because in the US, many of the endocrinologists actually do their own ultrasounds. In India, it's very difficult simply because of the PN&MC Act, that the Prevention of Sex Determination Act, that limits many of us from owning or using an ultrasound in our office. Although I would say that when in the right place, having an ultrasound is like an extension of your own hand. So this is the ATA flow part. But let me go on to ACR TIRADS, which is a modification of the previous TIRADS. Very, very good. That looks at about the way this thing is, and you can look at it from even a single picture that the radiologist gives you. A good representative picture gives you many things. But one of the things that I would tell you is, if you're not reading your own ultrasound, insist that your sonologist reports it. Why ACR TIRADS? Because you're not going to get a radiologist to use ATA, and I'll show you other reasons why. But certainly the ACR TIRADS is something very easy and that each of us can learn. There are 5 headings: composition, echogenicity, shape, margin, and the echogenic foci. And then you take points from each of these and add it, and then that gives you the TIRADS level. So I'll go through each of these and give you an exercise in this. So just hold on for a second. Just 1 second. Right. I just turned the fan off because it's making a lot of noise. So if you look at it, the composition can be anywhere from cystic to solid. The echogenicity is from no echo, right? That is, it passes right through, to hypoechoic, which means that it's very low compared to the surrounding. The shape, again, we had the quiz today, whether it's taller than wider, we talk about it, or wider than taller. The margin, whether it is nice and smooth, or is it lobulated, irregular, or there's this thing. And then, of course, what the calcifications that we now call echogenic foci. And each of these have points. I'll go through this quickly with you. I won't spend too much time. And from this, if you have 0 points, then there's no FNA, 2 points, no FNA, 3 points. FNA, if it's more than 2.5 centimeters, a TIRADS 4, more than 1.5 centimeters. And if it's a TIRADS 5, an FNA, it's more than 1 centimeter. Remember that less than 1 centimeter, even if it is suspicious, many of us will not FNA. So let's walk through this. I think I won't take too much time, but look at this. Nice margins, but look at the composition. We'll concentrate on individual components and then put it together. This is a cystic nodule. And you can see it is almost completely cystic, 0 points. This is almost always benign, but we look at it. This, if you see this picture, this is called a spongiform. It looks like sponges, right? In the past, when we didn't have these nodules, but when we saw a spongiform lesion, we would not FNA it because simply we know a spongiform lesion is completely benign, right? Next, look at this one. This is there are some solid elements and there are cystic elements. So it's low on the category, so you add 1 point. This is mixed cystic and solid. On the other hand, if you see this particular lesion, it's almost completely solid. Can you see this? And there's a small portion of cysticity, but it's almost completely solid. This would warrant a 2 points, right? So this is about composition. The second category, so composition, all the way from cystic up to solid. The echogenicity is comparing the lesion along with the side. A cystic lesion like this that has absolutely no echos in it is anechoic, does not warrant any points. On the other hand, look at this. This is a little more than the surrounding lesions, right? Surrounding tissue. So it's hyperechoic. The chance of it being a malignant or contributed to malignancy is quite low. It gets 1 point. On the other hand, if you see this particular lesion, forget the microcalcifications here, but can you see it's hypoechoic when compared to the surrounding? And therefore, it warrants a slightly higher point. On the other hand, if it's very hypoechoic, like this, can you see this? This is very hypoechoic. That is, when you compare to the surrounding thyroid tissue, can you see how hypoechoic it is? If it's very hypoechoic, it's almost 2 points. Look at this one. This is very, very hypoechoic. So this is almost always a malignancy. This is almost always a malignancy. Okay, that comes to the shape. Normally, when you, so remember that the dimensions in which you're looking at the ultrasound. So remember, the ultrasound is a cross section of the thyroid, right? And the way to look at it is from this side to this side is the width, and then up to down is the depth, right? So the best way for somebody to give you the data, please ask them to not use words like anterior, posterior, transverse, and cross section. You want the width, the depth, and the height. The height is used by using the longitudinal probe. The width and the depth is a transverse probe. Just like breast cancer, the rounder the lesion, the greater is the malignancy. Little clue for Om Lakhani's quiz. So normally it should be wider than taller. If it's wider than taller, then that's very, very benign. On the other hand, look at this lesion. On a transverse thing, it's moving backwards. That is, the depth is greater than the width. When this is present, there's a 69 to 70% chance of malignancy, and therefore it warrants 3 points. So taller than wider and wider than taller. Next is margin. Here is a beautiful margin. So almost as a halo around it. It is smooth. It's perfect. When you have such a smooth margin, so we were talking about composition. We're talking about echogenicity. Now we talk about margins. And shape, taller than wider, wider than taller. Then margins smooth, absolutely fine, and 0 points. On the other hand, you can have margins that are not very well defined, but these are not malignant. Therefore, again, these get only 0 points. On the other hand, you see this margin. This is very irregular. You see that it's not perfect. There is no rounding. There looks like some extrusion here. This is suspicious. It could also be what we call lobulated, and this is lobulated. And when you see lobulated margins or irregular margins, then your suspicions for malignancy is a little higher. On the other hand, if you see an extension outside the thyroid, then it's 3 points. That brings us to calcifications or echogenic foci. In the past, a lot of people were very interested in this particular one. It was called the comet tail artifact, but it really doesn't matter. A comet tail artifact is an ultrasonological phenomenon. No point needs to be given to it. On the other hand, if you have a macro calcification, that means when you call it micro or macro calcifications have shadows behind them. And remember, an echo is a shadow. So when you have a shadow, it's a macro calcification. It's usually benign. 1 point is given, right? Then these are what are called rim calcifications. Rim calcifications do not increase the risk of malignancy, but it's a very, very old nodule, and therefore a higher point is given for it. But this is the most important. Can you see these very small lesions? These are what are called microcalcifications. The correct term for it today is punctate echogenic foci. right? And if as much as possible, these actually, in many ways, are equal to the owl's eye bodies. And if I were doing an FNAC, and I do all my FNACs myself with the osteonologist, I try to direct the needle towards these particular microcalcifications because yield is higher. So these are called punctate echogenic foci. So what do? So you put all of this together, right? And then if it is 0, no FNA, 2 points, no FNA, 3 points, if it's more than 2.5, 4 to 6, more than 1.5. If it's 7 points or more, then you really want to be thinking very hard. So how does this compare? Very, very well, right? This shows how each of these have an odds interval. Can you see this markedly hypoechoic has an odds ratio of around 5.68? And of course, taller than wider, very, very high, 13.5. And irregular margins has an odd ratio of 10.5. And the presence of and the absence of echogenic foci has a negative predictive value. So the odds ratio for that is 0.7. So let's quickly do a practice because I know we're running late and I don't want to interject on more interesting time, but look at this nodule. So in your minds, you can take this score or you can put it on the chat box, but can you see this is very interesting. The composition of this nodule is a 2 because it's solid. Echogenicity, it is isoechoic with the surroundings, so a 1. The shape, it's not fully round, it is still, it is still taller, it is still wider than taller. You'll see that there are no echogenic foci there. The total score is 3, it's a TIRADS 3, right? And you want FNAC tips greater than 2.5 centimeters. So simple to do this. And with one picture, you can do this. You don't need to worry about it. Let's do one more practice. So this one, can you see it's hypoechoic? Not very hypoechoic, but hypoechoic. It's 2. It's almost solid, so its echogenicity is 2. The shape, it's still wider than taller. The margin's quite good. There's no echogenic foci. But if you notice, the TIRAD score is 5. And when your TIRAD score is 5, you really want FNAC. This was FNAC that was malignant. One more practice before I let you go. Look at this one again, very interesting. From the looks of it, you can already see the microcalcification. You can already see the echogenicity. But I always insist on going on a plan, and this is my plan. So the composition is hypoechoic 2. I'm sorry, it's solid 2, hypoechoic 2, shape still 0, margins, can you see these margins are irregular, 3, and echogenic foci, can you see these microcalcification? The total score is 10, TIRADS 5, and FNA greater than 10 centimeter. If it's greater than 1 centimeter, again, I would concentrate on this. The hit rate of a malignancy in this region is usually very high. You could actually use this. This is a TIRADS calculator. I don't know if you're going to see my screen. So, but this is a place where you can actually put these points up and use it. And this is what we do in our clinic. So I have an electronic medical record that we designed that's available. And it's very designed towards diabetes and endocrinology. So here is a patient. I'm just putting 2 patients that I saw today, right? So here is someone who I saw from Tripura, and I was so happy to see a radiologist using TIRADS in Tripura. But he had all the information that I need, a right nodule, and you can see this, that the echogenicity was 2, had microcalcifications, the margins were irregular, it was not taller than wider, the volume was 0.88 centimeters, and it was a TIRADS 5. This patient had an FNAC done where they called it follicular lesion. Now so people are not very good at reading B3s and B4s. So I have asked him to come back, and he said that he's willing to travel down. So I'm going to repeat an FNAC in 4 weeks. But this is somebody I would be very careful. Interestingly, I saw another TIRADS 5 lesion with a B2 lesion. We got a calcitonin, and the calcitonin was negative. But what do you do on this? Look at the cytology yourself, and if you can, these are the people that you want to get markers. There are discrepancies. Just another patient, I've been seeing this patient from, you notice that I've been seeing her from 2008, and you can see that she has no changes this time. She came 2 years after the COVID, 1.5 years. Can you see the last ultrasound? The nodule has not changed. The volume change is only 2.6%. But if you notice that the thyroid score, the lab calculated the thyroid score, the radiologist calculated as a 3, but when I looked at it, I thought it was a 4. And my plan was to do an FNAC, which she's going to get early next week. So which is better, ATA versus ACR thyroids? I'm sure you're going to hear a lot of stuff like this in the ATA, but I can tell you that look at this part, ATA versus thyroids. And if you look at the whole thing, you will see that the negative predictive value for ATA thyroids is a little higher, especially also, more importantly, for malignancy, even more importantly, for unnecessary FNABs. Irrespective, which I would suggest that whichever you're doing it, have a method to it. Make sure you understand how it is. Insist that the radiologist reports it the way you want it to be reported. And if you are lucky, like I am, have a way to plot it over years. I've been following thyroid nodules for 22 years. I have patients who had regular, my practice has changed, but they're coming to me annually and getting their scans and having my hand placed on the nodules and reviewing it carefully has not changed. And that's why, this is, in the future, you could use one of these. This is called artificial intelligence enhanced thyroids. You give it a photograph. It uses a slightly different thing. Remember, it's machine developed, slightly different, but you can see that this is there, and it works very well. It works very well, and you can use it. It's already available. To summarize, so I actually stole this time from this particular meeting. I, in fact, asked Dr. Bajaj if she'll be willing to have me speak on this, because I think it's something for us to learn and grow into the next level. A high-resolution ultrasound has significantly altered the management of thyroid nodular disease, is something that we know. The ACR thyroid is a significant improvement in currently available tools with high negative predictive value, low number of unnecessary FNACs, and I think soon we're going to be using AI-mediated this in the future. I'm going to turn you back to more exciting stuff. I'm happy to take any questions. Thank you for allowing me to share my passion. Again, I can see Prasanna's video. Thank you, Prasanna. You started me on this journey very long time ago, and I'm still following this almost 20 years from now.
If there's one question about importance of any thick halo and thin halo, is there anything difference?
No, I don't think there is. There's a lot of discussion on it. But it doesn't have a significant positive or negative predictive value, so I would not use it. I would stick with these numbers. These are very, very well shown. Every time you find one article that comes out that gives you some additional information, these are good. But I think the combination of the things I would suggest people do a systematic. I mean, I have it to a pat: composition, echogenicity, margin, shape, echogenic foci. Think of this in your mind and 1, 2, 3, 4, 1, 3, 4. Use a simple way to go.
And Dr. Pankaj, so halo is not in the thyroid score now.
I have a halo around me, if you notice it.
Yeah, I can see that.
But it doesn't help me.
Thanks very much, Chris. We enjoyed your talk, as always, very nice and clear. Thank you. I think you also went there to listen to the score from Om now. Correct answers and the winner from Om now.
Okay, over to you, Om.
Thank you. Thank you, Sheshadri sir, for the wonderful talk. I think I'll start sharing the answers and the results. Okay. So first and foremost, to the participants, apologies for the technical glitch. I hope, we tried to solve it to a lot of extent, but I hope, again, apologies. And again, I mean, this is not a formal quiz, so I hope, if there are some issues, I think we can take it with a pinch of salt, as, we're discussing thyroid and how to do it. Okay. So this was the first question on a very interesting interaction between a surgeon and an endocrine physician. And we had a very interesting interaction today as well, right at the beginning. But earlier it was always, for Graves' disease, surgery was standard, and one surgeon was not only very famous but very rich because of so many surgeries he did. And then came the physician Edwin Atwood, who actually suggested the treatment of PTU, and treatment has never been the same. And this surgeon was Frank Lahaye, right? So he was a surgeon. He was a proponent of subtotal thyroidectomy for Graves' disease. This is the Lahaye's technique. Is also very famous for palpating the thyroid gland. So this interaction has been in the annals of history in endocrinology and become very famous. The second question was, and I think Dr. Seshadri answered this. So I hope it's clear, but the answer here is it's a sphere, right? So I think he said rounder the better, rounder more likely to be malignancy or something like that. So I think that's the take-home message. So sphere shaped nodule is associated with higher risk of malignancy. You can see the the reference here, and you can kind of have a look at the article as well. Now, this is a question about 30-year-old primary gravida. Anyone who, among the experts would like to have a go at it? A little controversial here. That's no question would be without controversy, right? So you have a lady with TSH of 4.1 and TTPO is positive, first trimester of pregnancy, no history of abortions. Would you treat this or not treat this? Well, the ATA guidelines says the option A, that is start her on levothyroxine, right? So this is the screenshot of the, a sort of a modified version of the guideline. TSH 4 to 10 and TTPO positive. Now, they also recommend use of local cutoffs. So perhaps that 4 may be something like a 3.6 or 3.9 based on local cutoffs, but I think, more or less the gist is here. The question was about extracts, and I think, Dr. Arpan Dev leaked the answer saying, and Dr. Seshadri also said that, there's only one Frenchman here. This Frenchman is Charles Brown-Séquard, right? So the famous Brown-Séquard syndrome. He's famous in neurology, but he's a very famous, endocrinologist as well. If you can see, he actually, started what is known as organotherapy. Perhaps in today's world, he would be called a quack. That's what he was called then as well. He took extracts of tissues from various animals and, used it. And this is the same idea which George Murray used for thyroid extracts. So, that's the irony that Brown-Séquard gets very little, credit for something which he started in endocrinology. Okay, so this is again, I think a lot of people got this correct. This is a recent study published in New England Journal of Medicine. Anything published in NEJM does get a lot of press and data. So the answer here is, so we are comparing, RAIT versus no RAIT in a low risk thyroid malignancy, and the found was that the use of no RAIT was non-inferior to use of RAIT. So I think perhaps then the guidelines perhaps now would easily go towards the fact, very firmly towards the fact that all people with low risk of thyroid cancer need not require routine post-operative radioiodine therapy. So that's the current recommendation as well to a lot of extent, but now it's very firmly established with this study. Then of course, Arpan Dev sir, any guesses for this? Which is banned in WADA? LT3, LT4?
I think LT3 is banned.
Yeah, actually neither is banned, right? So neither of them are banned. So it's a gray area. Now, whether somebody gets a boost out of taking an LT3 in a sprint race, I don't know. But at least as of now, they are allowed. So perhaps a biological hack. So this is again a paper in JCEM which actually discusses this point. Whether it should be considered some form of banning here. But it's still a gray area. Okay. So,
I remember, the Shen1 was actually one of the substances that was the thyroid. You have taken thyroxine or T3 or T4 without thyroid disease. You remember that he was banned for 1 year.
Okay, so must be a case-to-case basis because as of now it's not amongst the banned list. So perhaps there might be some individual case basis. I think where they would have probably considered.
Can I give a point?
Yes, sir. Yes, sir. Please,
very interestingly, the latest thing is using ketones, right? In fact, the Tour de France for the first time was won by the Brits. And for 3 years, they've been using ketones, and ketones is not a banned substance. So very interesting stuff to have.
I think, science always, people always find a hack, right? That's the reality.
Yeah, so
it's not banned.
Have a ketone drink before you do anything else.
True. Okay. So I think this is a question which I think for endocrinologists, it's day in, day out kind of thing. But for physicians as well, other specialties, it's something which is very important. So this patient had a coexisting cortisol with, subclinical hypothyroidism. So in this patient, you need to treat both. There was indication to treat both. This is actually an APS, autoimmune polyendocrine syndrome. But you need to start glucocorticoids first before you start the patient on levothyroxine. This is interestingly, we have one paper in one thing which I did during my residency, which was published in Thyroid Research and Practice. This was an article on APS2. So I think a little callback to that. Okay. So CMC Velo, they use cord blood for cutoff. Again, they published this, and the cutoff they use is 25. So that's the point here. And this is again, they use this. This was published in Indian Journal of Endocrinology and Metabolism. And they say that, they re-verified the data, and they said that you'd continue to use 25 as a cutoff from cord blood. Okay. Very straightforward again for endocrinologists. So this patient had low T3, normal T4, low TSH. We often get such references from the wards or from other specialties. This patient basically had dexamethasone, which caused the suppression of TSH and T4 to T3 conversion. Perhaps you could call this a form of non-thyroid illness as well. Here. So that's the idea here. So this is, I think, I'm sure everybody here, Dr. Arun, sir, any answer here? So this is Rosalind, famous Rosalind. Right? But what's the contribution to thyroidology?
It B.
Yeah, right. So absolutely. So Rosalind Yellow, the second woman to win a Nobel Prize. Very important as well. I think it probably changed our branch, I think, for good. I think is that she used radioactive iodine for studying iodine metabolism in thyroid tissue. She did a lot of work in thyroidology. So of course, she's known for insulin assay, but she has a lot of contribution.
Actually, her first discovery was the insulin assay because Burson, she was working in Burson's lab, and Burson died much before Yalow got the thing. So the first was the insulin, actually the somatostatin assay, and then the insulin assay, and then the thyroid assay.
So I think the question was that what was a key contribution to thyroidology? Addition to that. So you're very right, and that's what. In fact, she was alone. She received the Nobel Prize alone. I think she shared it with Burson later. Which probably was very kind of her actually in that sense. In a recent JCM publication, so this is about post-operative vocal cord paralysis. Again, a JCM paper. And they found that actually the weight of the thyroid specimen correlated with the risk. So, do a post-operative weight of the specimen, and then higher the specific weight, more the risk of post-operative vocal cord paralysis. It's easy to understand, but perhaps, difficult to answer when this question is in front of you. But a lot of people got this right. So, okay. So, question number 12. Pramila ma'am, is she there? I think she can answer this question. This is a paper in Thyroid Research and Practice, and 20% of people after subacute thyroiditis in their series develop permanent hypothyroidism. And this is very similar to Sarita ma'am. What's your generally what percentage of patients you see who develop permanent hypothyroidism? Okay, we'll move on to JCM paper here, and interestingly, what they found was that the answer here is B. So they found that there is, higher TSH level may be associated with higher fluid intelligence in young women, right, within a euthyroid range. So very interesting, and again, it's a very interesting paper to read also. So I think perhaps you can go back and read this, and I think some area of this we need to really explore and understand a little bit. This is again a paper in Thyroid Research and Practice where they found that patients who are, if you talk about metformin effect, so they found that metformin significantly reduced TSH level in PCOS women with underlying thyroid dysfunction, while it had no effect in women without underlying. So with euthyroid women, there was no impact, but it did reduce TSH in women with hypothyroidism and PCOS. The ratio here is 0.3 picomoles per picomoles. Actually gave away the answer because I asked for the units here. And if you see the units, there are only two options. So either it's more or less. You have to choose one of these. So I think it was pretty straightforward then. But again, most people got this right. But there's a couple of people who got it wrong as well. This is again a paper from IJEM in the recent series. I think this I don't even remember the answer here. So its answer is D. This was one of those questions where you just had to put it, right? This was one question which had to be random. So the answer is there is a correlation between polymorphism in type 2 deiodinase and reduced risk of COVID-19 mortality. So paper is there. So Sheshadri sir, what's your answer here? Cytopathological feature most sensitive for PTC?
The papillary cores and nucleus.
Absolutely. So, you learn from the master, right? That's the answer, right? So papillary, cores and nuclear grooves, that's the answer. That's the most sensitive amongst all the, things they studied in IJEM amongst the cytological features. Okay, so very interesting paper again, well done, well written paper. Study from Bangladesh. Now, of course, I said it's a metal, technically it's a metalloid perhaps, but Arpande sir, any guesses?
I think he showed his arsenic.
Yeah, right, it's arsenic, okay. And so this is a paper again from Thyroid Research in Practice, in the recent current edition. I think I'll go and read this, this is interesting. And we had to put this because we had to have something to do with ME. And of course, this is not purely a thyroid question, but answer is C. And again, a lot of younger generation, people from I don't know where they are, but I know them as residents and trainees, and they got this answer absolutely correct. Answer is C. ME4. And of course, the last one, again, Sheshadri sir, I think, you would, I think, easily answer this. So this is a lady with multinodular goiter. She has a low T3, low TSH, normal T3, T4. What would you do for this patient? Again, a lot of people got this right. Answer is you go for a scan, and if there's a cold nodule, you do an FNS, right? So again, this is the first step in the ATA guidelines. TSH, if it is high on normal, go for an ultrasound. But if it's low, do a scintigraphy, hot nodule, consider RAIT, cold nodule. It's a simplified version of the ATA guideline in that sense. But sir, would you agree, Sheshadri?
Right. Absolutely. I think the important word is not to use the word low, but suppressed.
Okay. So thank you to all the seniors here today. And I'll now declare the winners. So again, apologies if you face technical glitches. This is a fun quiz rather than, but a lot of you got a lot of answers correct. It's just a matter of one or two questions here or there. So the second runner-up is Dr. Parul Gupta from Jodhpur. Congratulations to her. And the first runner-up, that is the second prize, goes to Dr. Sravya from Bhubaneswar. And the winner today is Dr. Sumaya Abdul Kalam from Hyderabad. She wins.
Congratulations.
I think she got only one incorrect. She got all of the rest of them correct. It's quite remarkable. So congratulations to the winners, and thank you to Dr. Sarita ma'am for this quiz, for allowing me to do this, and thank you to everyone. And
the best part of the quiz, it was written that panelist and host cannot participate. I was very happy to see that.
You would have gotten a total of 3 right.
Thank you very much. I'm sure all of you enjoyed the way I enjoyed. I will hand over to Dr. Prakash now.
Yes, thank you, Dr. Arpan. All the 3 speakers have done wonderful job, and Dr. Sheshadri has been teaching us thyroid nodule management for last 20 years. ITS conference at Bombay also, and nowadays today's lecture was much more informative than that. And both the speakers talking on the medullary thyroid carcinoma has given a good informative talk. And Om Lakhani's mind sketching quiz was again very good. And I congratulate you all for being contributed to improve knowledge for all of us. And now I hand over to Madam Sarita Bajaj for
Thank you.
finishing.
Thank you, Arpan. Thank you, Prakash. I think for the wonderful chairing and the moderation. I think the most important take-home message from the duologue was a good history taking and the pedigree chart. See, remember how Thomas Paul highlighted the fact that the first thing, the most important thing you have to do in the OPD, as soon as you get a case of MTC, is to make a pedigree chart, and you then move on from there. So I thought that was a very, very important take-home message, and that is applicable from the physician's perspective. Om, I knew your quiz would be absolutely A1, and we've all enjoyed it. We've really learned from it. Krishna, your talk, as usual, like I've said, you're a master orator, and nobody can deliver better than you. Thank you. Thank you so much. Over to you, Arun.
Thank you, ma'am. I mean, again, another wonderful session. I suppose the proof for the pudding is the fact that even though we are about 20 minutes late, we still had about 100 people in the audience, listening to this. So I think that is just the proof to the fact that this has been high quality. Thank you, everyone. I'm not going to name each and everyone. Ma'am has already done it. Thank you so much for delivering such a wonderful session. I just need to, before we conclude, just need to tell you about next week. We have the thyroid clinics next Wednesday, and you can see the program there. We will send it again on the email as well as on the WhatsApp, and the information will be circulated. And very importantly, if you can project the next slide, on 15th of May,
25th.
Sorry, 25th of May, let me correct that again. 25th of May is the World Thyroid Day, as you all know. World Thyroid Day webinar will be a slightly extended session starting from 7 to 9:30 p.m. So please block your date. We have got a wonderful program. We have international faculty as well as very famous national faculty. So it would be a wonderful session. So please block your date. We will inform you all well ahead of time to the program. So that's, please do make a note of that. So that concludes this evening's session. Thank you once again to everybody who has been listening to the program, all the speakers, as well as everyone who attended this program. So thank you once again, and good night.
Thanks to organizers, and congratulations to ITS team.
Thank you to the digital team. I think Ashmita is with us today. And of course, we also have our partner with us, Medisage. Rahul is there representing Medisage. Thank you, Arun. Thank you, Mini. Thank you, Pramila, Arpan, Om, Prakash, Krishna. Very, very good night to you.
Good night.
Good night.
Thank you very much. Congratulations to you.
Thank you.
Thank you. Thank you.